Okay, then, so now we've learned a bit about dolutegravir. Now, how are we actually going to use it? And we're first going to look at, in first-line regimens, where is dolutegravir going to fit in? So here is our summary of our first-line regimens going forward. Neonates stays the same. They'll start AZT3TC nevirapine until they are over 3 kgs and over 4 weeks of age, or if they were born prem, remember they need to be over 42 weeks corrected gestational age, then they can be changed to abacavir, 3TC, lopinavir, ritonavir. Then what has changed is that children all the way up to 20 kgs will be given abacavir, 3TC, lopinavir, ritonavir. We've scrapped the efavirenz for children, starting children on efavirenz. If they are already on efavirenz and their viral load is suppressed, they will remain on efavirenz. But if they are a new child starting ARVs between 3 and 20 kgs, they will start abacavir, 3TC, lopinavir, ritonavir. Then, when they reach 20 kgs, this is when dolutegravir can be used. So this is the lowest weight at the moment. It might come down in future, but at the moment, we can give the dolutegravir 50 milligram tablet once daily in children over 20 kgs, which is great because we didn't want to bring in millions of little tablets that complicate the supply chain. So children who are 20 kgs can go onto abacavir, 3TC, and dolutegravir. When can they go onto TLD, our fixed dose combination tablet? That will be when they are over 10 years old and over 35 kgs. The 35 kgs is because of the tenofovir dose, and the age 10 years old is also because of the tenofovir. It's not because of the dolutegravir. Because the dolutegravir in TLD is also 50 milligrams daily. It's the same as the dolutegravir tablet that they'll take 50 milligrams daily. So this change is purely because of the tenofovir. And you'll notice that the tenofovir age has now changed. It used to be 15, that you had to be over 15 to take tenofovir. Now we've brought it down to 10 years old. The reason for that is because we want to get as many people as possible onto this TLD tablet. And generally, internationally, tenofovir has been used in many children. They have a much better ability to monitor the bone mineral density and the creatinine renal function than we have had in South Africa. That's why we've been playing it very cautious. We didn't want to risk causing side effects in children, but generally it looks pretty safe to give children from 10 years old tenofovir. But we will be monitoring their creatinine, and there is a different formula for calculating their creatinine clearance. Okay, it's the Cunahan-Barrett formula, and it is in the guidelines, and I think it's in your manual, but it's in the guidelines very clearly. It's the one that uses height and in it. So that will be used for children from 10 to 16 years old. We'll use that formula. Whereas if they are over 16 years old, we can use the normal the normal EGFR that is given in the lab results. Okay. And then just to note that when changing at each of these stages, we generally, remember, we never want to change one drug in a failing regimen. So before changing, we need to take a viral load for all of these changes, except for the neonates, because they might have only been on for 4 weeks. We don't do a viral load at that change. So at this point, we can change straight, but at every other stage, you must do a viral load, and they must have a suppressed viral load. Then for women and adolescent girls, this is where it will get a little bit interesting. And so let's find out what they'll do. So the first thing to assess, so this is in all women and adolescent girls over 10 years old, over 35 kgs, because of the tenofovir. The first thing to assess is, are they of a woman of childbearing potential? If the answer is no, easy, they can go into TLD. But anyone who goes onto TLD needs to be counseled about all the risks and benefits of dolutegravir, efavirenz, the potential risk of neural tube defects, and contraceptive options and their fertility status. So it's those same 3 steps I mentioned earlier. So we're trying to make it quite simple. Those 3 steps will be repeated over and over. If they are of childbearing potential, then we have to decide if they're pregnant or not pregnant. And in the abridged guideline, it says you ask the mother when her last menstrual period was, if it was at the appropriate time, as regular for her, and if she's on reliable contraception. If she says no to either of those, she needs a pregnancy test. Okay. Then if she's pregnant, we're still going to give her all the necessary information. So ask her what her future pregnancy plans are, because she might be pregnant now, but what's going to happen afterwards? And ask her and give her the information of dolutegravir, efavirenz, pros and cons. If she's in the first trimester of pregnancy, we recommend that it is better to use TEE, but the patient still has a choice. Okay. If they are in second or third trimester of pregnancy, we recommend that it's safe to use TLD, but the patient still has a choice. So the bottom line in all of this is it comes down to the patient's choice, but we have to give them the informed, allow them to make an informed decision. If they are not pregnant, and this includes women who are breastfeeding, we again provide all necessary information on dolutegravir and efavirenz, provide her with a choice of contraceptions, options. If she does not wish to become pregnant and is using reliable contraception, it is recommended that she changes to TLD, but it's her choice. If the client does wish to become pregnant and or is not using reliable contraception, she still can have the choice between dolutegravir and TEE. Our recommendation would be TEE or contraception, but she can make her choice. So how are we going to help them to make their choice? These are the 3 steps. First step is to understand her pregnancy status and her fertility intentions. Is she pregnant now? Does she want to fall pregnant? When does she want to fall pregnant? In the future, not at all. Step 2 is explain the risks and benefits of dolutegravir and efavirenz. And remember that efavirenz remains a safe alternative. It's not like we're saying efavirenz is now terrible. We've been using it for the 5 years, but terrible. And then the third step is discuss all the options of contraception. And we always will recommend dual contraception, perhaps a hormonal with condoms, because we want to protect from other STIs as well as pregnancy. So just to go into more detail on the risks and benefits of dolutegravir and efavirenz, because we might know them, but we want them to be very clear for all our clinicians so that they can very easily tell patients the pros and cons. So the benefits of using dolutegravir is that it provides rapid viral suppression. It has a high genetic barrier to resistance, which again I will elaborate on later. It has no interaction with hormonal contraceptives, and side effects are mild and uncommon. The risks of using dolutegravir is that dolutegravir may increase the risk of neural tube defects if it's used before or in the first 4 weeks after conception, and there are drug interactions with rifampicin, metformin, anticonvulsants, and polyvalent cations. Then the benefits of efavirenz is that it is safe in pregnancy. There's no significant interaction with TB treatment or those other drugs. But the risks of efavirenz is that there's a low genetic barrier to resistance, there are drug interactions with contraceptives, and there are neuropsychiatric side effects, and just generally a few more side effects. Shem, I see you all taking photos. This is all in the manuals, and we will update the manuals and send them out to you. You'll be provided with all of these slides. Yeah, you're getting everything. You guys are the master trainers. You're getting everything. You're getting these slides with notes at the bottom telling you exactly what to say. Okay, it's all been done nicely for you. You don't have to worry. But I'm happy to see all the enthusiasm. Okay. So then, another important thing that everyone has been querying about is if she chooses to take dolutegravir despite recommendations and despite saying, I don't want contraception, then we must document her choice in writing in the clinical notes. How do we do that? Well, we all know the clinical notes, the summary page. In the notes section over here, we can write, patient requests switch to TLD, patient is of childbearing potential, neural tube defect risks have been discussed, patient is aware of the risks and still wants to switch to TLD, her last menstrual period was then, no current sexual partner, or whatever story you want to put in there, you document in notes. Then underneath notes is this little line that I think most people completely ignored, which is the family planning section. And from now on, we are going to fill this in. We'll say no current family planning, patient declined, or patient on, Depo-Provera, or whatever they're on, or if they declined, we'll put it in there. And then thirdly, at the bottom, in the assessment, under adherence, we can say patient is aware of dolutegravir risk, they consented to TLD switch. Then moving forward onto dual treatment of HIV and active TB. We already know that there's an interaction here, and TB has always had a huge influence in our ARV regimen. So how it's going to impact here is that efavirenz has no interaction with rifampicin. So efavirenz is great in that regard. Dolutegravir does have significant interaction with rifampicin. So how we're going to decide what a patient should get or change to. If the TB treatment is started first, and they're not yet on ART, then we are going to start them on an efavirenz-containing regimen, because that is much easier and we don't risk getting dolutegravir resistance. And it can just be for those 6 months until two weeks after they've finished their TB treatment. Then they can change to TLD if they want to. If they are already on ART when we're starting TB treatment, then if they're on efavirenz-containing regimen already, continue that until 2 weeks after they finish TB treatment. Then if they want to change to TLD, they can. If they are already on a dolutegravir-containing regimen, then we're going to have to boost them with that additional dolutegravir dose, the additional 50 milligrams of dolutegravir. Okay? So the difference here is just that the efavirenz is nice because it's once daily, whereas the dolutegravir will be twice daily just for those 6 months plus 2 weeks at the end, and then you go back to normal. Then the next topic is how do we reinitiate ART in people who have interrupted their ARVs previously. So we've changed from defaulters to now interrupters. It has less stigma because we're all doing the Welcome Back campaign. So what are we going to do? We're going to take a thorough history, try and find out which drugs the patient was on previously, for how long, why did they stop their ARVs, did they have side effects to their ARVs, and can we try and find any viral load results? And don't just ask them, they often don't know the answer. Try and look on LabTrack, on the NHLS system, and try and find those viral load results. If the patient was clinically well on their first-line regimen, if their side effects were not the reason for stopping ART, and their viral load was suppressed, or we can't find the viral load, then we're going to restart them on their original regimen, being TEE. Okay, well, if that is what it is, TEE. Then what we'll do is after 3 months, we'll take a viral load. Most of them, if they don't have resistance to TEE, most of them should suppress by 3 months. If they do suppress and have a viral load less than 50, then they can be offered the option to change to TLD. If they do not suppress, we're going to give them another 3 months and take a viral load. If they are now suppressed, they can have the option to change to TLD. But if they are still not suppressed, then we manage them as a high viral load, following the high viral load algorithm. Okay, is that clear? So we're giving them a bit extra time here to make sure. So it's in keeping with our normal viral load failure on TEE to have 2 high viral loads before we say that they have resistance. But just remember that this is when the patient is clinically well, no side effects, etc. So if they are very ill, if they had side effects, we are not going to start them on their TEE again. We can consult an expert. Switching between efavirenz and dolutegravir in stable patients. So this is, I think, the big question that we all came here to find out, is how do we get our normal patients onto dolutegravir? The overarching principle, which we've had forever in HIV medicine, is never change only one drug in a failing regimen. So we have to make sure that a viral load is suppressed if we want to change only one drug. A single drug switch requires viral load under 50 copies per mil in the last 6 months. Okay. And another very important point here is that we are not going out and doing viral loads on everyone now so that they can switch. We are keeping within our routine viral load monitoring because we cannot afford to do 1 million viral loads. Our laboratory system will collapse, and also our dolutegravir rollout has actually been planned according to how many people will have viral loads done at different times over the next year. We can't suddenly change everyone in August. It won't work. Okay, so no additional viral loads for people. You wait until you assess if they've had one in the last 6 months, then you can assess it and use this algorithm. If their last viral load was 7 months ago, we're going to wait until their next annual viral load. So it'll be 5 months' time. Okay, is that clear? Good. Okay. And then remember, when switching, we always have to counsel patients about the risks and benefits of dolutegravir and efavirenz, provide counseling on contraception options, check for potential drug interactions, warn clients about new side effects. They might, as much as we say that patients generally experience much less side effects on dolutegravir than efavirenz, some people might experience a new side effect on dolutegravir that they didn't have on efavirenz. So we know that every patient is different, and they must all be warned about everything, and we will offer a patient the choice of remaining on efavirenz or switching to dolutegravir. So I feel like a stuck record going through this, but that's how we will all feel in this training because we want everyone to go out with this message solidified in their brain. So how do we do it? We'll check their last viral load. Okay, so routine viral load monitoring is exactly the same as we've been doing it. In the first 6 months on ART, if they're virally suppressed, then we repeat at 12 months and 12 monthly thereafter, exact same as before. So if they've had a viral load done in the last 6 months, if it is less than 50, then we can provide information about dolutegravir, risks, benefits, contraception, give them the choice to change to TLD or give them the choice to stay on their TEE. If their viral load is, let me jump to over 1,000, then we're going to ensure that the elevated viral load is correctly managed as per the high viral load algorithm, which I'll go through just now. And once virological failure is confirmed, we cannot ever change one drug. The patient then, if they want to take dolutegravir, will have to change from tenofovir to AZT, or if they were on AZT to tenofovir. So we'll have to change 2 drugs. Then if they land up in the middle category where their viral load is between 50 and 999, what are we going to do? We'll do a thorough assessment of why is their viral load high, and I'll go through we've got an A, B, C, D, E that we'll follow. And we'll repeat their viral load in 3 months. If it is now less than 50, they can have the option of changing if they want to. If it is now over 1,000, treat as viral failure. If it is now still between 50 and 999, we are giving them the option to change to dolutegravir. Okay, and this might seem a bit confusing, like why are we bothering if we're still changing? And there was a lot of debate and discussion over this within all the experts in the guideline committee. The reason for this, because WHO guidelines are saying if your viral load's less than 1,000, you can switch to TLD. But our experts wanted to be extra cautious. We didn't want some of those patients who are, have a viral load of 500, 900, they might be developing resistance, developing treatment failure. We don't want to risk them going onto dolutegravir with a 1-drug switch and then developing dolutegravir resistance. So the reason they put this extra step in is to just check, is this person's viral load going up? Is it going to treatment failure? Is it going to above 1,000? So the first one, if it's 500, let's try and assess adherence, sort out everything, repeat in 3 months. If it's high, then treatment failure. If it suppresses, great. If it's still in the gray zone, okay, fine, we'll say they can switch. Okay. Is that clear? Because I know this is a little bit of a complicated one. So you'll be happy to know that this table has been nicely simplified compared to our previous guidelines, which were very complicated, especially for the pediatric population. I had to refer to that all the time. So now our starting criteria for cotrimoxazole is the exact same as it used to be in the old guidelines, but the stopping criteria has been simplified. Okay, so 1-year-olds will all continue until they're 1 year old. When they're 1 to 5 years old, they'll discontinue when their CD4 count is over 25%. If they are an HIV positive child under 5 years old and they actually had a PJP infection, they will continue until they are 5 years old, and then continue until their CD4 count is over 200. So you all remember why children under 5 years old, we monitor their CD4 percentage, and children over 5 years old, we monitor their CD4 count. Okay, so that's why it's percentage under 5. And then HIV positive adults, older, and children older than 5 years old, will stop after the CD4 count reaches over 200. Okay, and so what you'll note here, these are new, and that only 1 CD4 count is needed to stop cotrimoxazole. Remember, we used to say you need 2 CD4 counts over 200, 6 months apart, and we weren't really monitoring CD4 counts 6 monthly, so it was a bit complicated. So now this has been simplified. If it's over 200 once, you can stop cotrimoxazole.